And we're live.
Welcome back to House
Go
Healthcare.
home.
Sorry for the technical difficulties. All right.
Okay,
So we are not going to put anything up on the screen. We have what you were showing us on our webpage.
you don't have my slides, but you have the language we're going to talk about, and you have an excerpt from the designation rule, and I just have a few remarks to make. So I think it'll be fine without the slides as long as I'm looking at them. It's just to keep me on track. Okay, so where we were, we have designation, and that's why this is an issue at all. So in most states, there is no designation for home health, and home health agencies have a lot of flexibility about what referrals they take and and don't take. Okay, so this would not actually be even a topic of conversation in most places. Yeah. So there is a statute that outlines our broad obligations and then calls for rulemaking, which is what the designation rule is. So most of the detail about our obligations under the designation are in rule, not in statute. And it's been in place since 2007, and this is a new version that went into effect in 2019. So this has been around a long time. So under the designation rule, because of this obligation to serve all eligible individuals who for designated services, there's only a narrow set of circumstances under which discharges are allowed at all.
Can you explain what that is?
Yes, so meaning if someone is receiving home health services and the agency wants to discharge them, meaning say we're no longer coming to visit you, there's only a few sets of circumstances where discharge is allowed. I mean, and it's really narrow. It includes things like your course of treatment is complete. That's actually listed. So there's only a few things, but safety is one of the things that is where we are allowed to discharge if there's a risk to staff. And so we do occasionally, and it is pretty rare, discharge individuals because of the risk to staff. There is in the rule, it specifically says we have to work to mitigate the problem before doing that. So there's an expectation that there will be a process to see if the problem can be solved. So for example, if it's a dog, and the dog can be trained, that might be something that could be worked out. And then with any discharge comes a notice of why, and there's a whole list of things we have to put into the discharge notice. And then there's also appeal rights, and there's an appeal process. So, and so it's a comprehensive process. It takes up 4 pages of the rule. And that's what I provided you that excerpt if you're interested in it.
Good.
So the reason we need this language is because as things are written, what's happening is that if an individual is discharged from home health for a safety reason, and 3 months later that person has another hospitalization and there's another referral to home health, there is no process by which we can say no to the referral, because there's very few reasons that we're allowed to say no to an initial referral. Okay. And so what's happening is sometimes agencies have said no, it has gone to an appeal eventually to the Human Services Board, and they have said you have to go back and make a visit and see what's going on. Even if you then discharge again under the whole process, they have demanded that agencies go back. And so what we're saying is once we've gone through this whole process of discharging someone for safety, which has an appeal attendant to it, at that point, we need to be able to have flexibility about whether we would accept a referral for that patient again. That's what we're asking for. That's what the language does.
Okay.
So it clarifies something that the rule does not currently allow for.
So can I just stop you there?
Yeah.
Make sure everyone understands that. Go
A
ahead.
little fuzzy.
Okay.
Are we talking about, Jill, the language in blue you've put on?
I'm talking about the whole, so if you're looking, it's section 3 of the bill.
Yeah.
What you're looking at is my proposal.
Yeah.
So that's what the Senate did, and what's in blue is what I'm going to ask that
That's
you
right.
adjust. So I will get to the blue in a
Okay,
second.
so that's not what we're talking about.
I'm just saying, why do we need
In-
anything?
In general.
I'm starting with why do we need a bill?
Okay.
Why do I need any of this language?
Okay.
Does that help?
Okay, yes,
Yeah.
that I understand.
Yeah.
Okay.
Okay, good. Thank you for pausing me. I appreciate it. So what we're saying is once there's a known risk to staff in a home, we cannot just send staff back. And really, we can't make them go. And also, we really want to keep our staff, and it's pretty hard to keep people if they feel like they're going to be sent back into a place where there's been a serious safety incident. But the rule really doesn't allow for that. We can discharge for safety, as I said before, but we can't deny an admission for safety. That's the issue. I think I already said the next piece I was going to say. And so yeah, that actually is going to start to bring me to the blue language. So let me actually open that up.
Before that, Art, did you have a question?
Yeah, well,
Yeah.
I just wanted to ask you, is there any provision to send like law enforcement with? No, nothing.
So you'll hear from my agencies, sometimes they try to do that, but there's nothing that requires law enforcement to help us.
Help you, okay.
Yeah, so there's no promise of that, or no way that we can be sure that we would be able
But
to
you
be
can ask
assisted.
if you-
We can,
You can make an arrangement,
we could,
you could.
but
All
yeah,
right, just thought I'd.
yeah. But I mean, I think we all know that there's no sector of our world that is not challenged by staffing.
Right.
Yep. But it's a good question. So I'm now looking at the language.
Hold on, Jill.
Yeah.
And just speaking from experience of having security show up at when there's a behavioral crisis, at least in the hospital, having law enforcement show up is not always productive. Nothing to do with what law enforcement is doing, but how the person that's in crisis is going to respond to having security.
Right. Although often we're talking about really less sort of someone who's in a mental health crisis and more people who are violent people. Yeah. So what we're asking for, you've seen the language from the Senate, and what I provided to you was the changes we'd like to see to that language. So the Senate mostly took what we had offered as language, but they added the phrase, and the behavior or conditions causing the discharge cannot be mitigated or eliminated. So we want to make sure it says reasonably mitigated or eliminated. We want to make sure that it's sort of possible to do the mitigation given the resources that we have.
So we're just adding reasonably.
Adding reasonably. And then because of this issue with having been sent back to check, we want to make sure that it's clear that nothing in this provision means that we're required to go back to determine if the risk can be mitigated or eliminated. So we might make a phone call to see what's going on, but we don't want to have to be required to go back physically to see what's happening.
Leslie?
Is reasonably a legal definition, or is it sort of?
Our lawyer suggested it.
Okay.
I'm not a lawyer, so I don't feel like I can say more than that, but I did ask him what we should do with this language, and that was his recommendation. So
Maybe there is.
that helps.
Art?
Not to keep the questionnaire here, but the statement in blue,
Mhm.
how would you ever find out if the danger is mitigated, if somebody didn't go back? I mean, how does it get resolved? Or does it ever get resolved?
It may not. I mean, I think what we're saying is it might not. We would certainly make a phone call. So if the person who was the source of let me back up. I didn't say this. Often the safety risk in the home is not the patient.
Okay.
Sometimes it is.
That's important to know.
Often it's an adult son.
And we're gonna hear, I think.
You're going to hear a lot more details, but that actually is an important
Yeah.
for the context. It sometimes is the patient, but it's often
Okay.
someone who's living with them.
So with that said, so you would call and say, is John Smith there? Is your son there? Or whoever the violent individual
Is he
is?
still living with you?
And if they're not, then
We might
you
consider it.
Consider it.
We
Okay.
want the flexibility.
All right, but there's no requirement that you go and look to see if the individual is there.
We're asking you to make sure there isn't.
Okay.
Mhm.
Okay.
Today, you would be required.
Could be required. And I think what,
You would be
Required to go.
Today, without this language.
Right.
and really what's happening for agencies is they're getting caught between regulations because they also have an OSHA, they have a moral obligation to their staff to protect them. They have a desire to protect their staff to make people want to continue to do home health. They also have OSHA obligations to protect their staff. And it's pretty hard to do this, to do the current state where we have to go back and protect staff in the way that we also are obligated to do so.
Could I question further just a minute? Not to pick apart this, but.
That's okay.
So right today, you go, an adult is violent at the
Mhm.
place, or you perceive it to be, I guess, however that works. And so you leave without giving the service maybe.
It might happen, yeah.
And then the next week you have to go back without,
So let me explain. So what will happen is we would discharge them for safety. We'd say, this health episode, this service is over.
Yeah.
This happened. Here's your notice. We're not coming to do visits anymore for this referral. So every time someone comes to home health, there's a referral from a physician and they say, hey, this is what this person needs. And so they need home health until these treatment goals are met. Home health is an intermittent service. You get it.
okay.
It's often after a hospitalization.
Oh,
So what can happen is we discharge for safety. We don't take care of that person for that episode. They get hospitalized again. Referral comes back to us for a subsequent hospitalization. And they're
Okay.
saying, will you come do home health for this round of need? That's what
okay.
so it's
You
really
go when you don't have any ability to call.
to say no on the admission. We don't have the ability to say, we discharged this person for safety 3 months ago. We're not admitting this person to home health today.
And the issue with the various, OSHA versus everything else, again, we're one of the few states that has it set up this way.
The designation at all, right? So we can't make choices in the way that other states where you could make all kinds of decisions about who to accept onto a referral.
Leslie. So the first is the legal definition. There is a legal definition that's just rational, appropriate, ordinary, or usual in the circumstances. So that
Okay,
very reasonable.
thank you for looking that up.
Yeah. So what does it mean to be designated? We're very few. There are few of us for whatever reason. Is there a reason to become undesignated?
That's a bigger question.
Yeah.
And I think
Really
it's,
not for now, but I'm wondering about what advantage there might be, but okay, never mind.
Yeah, that's not a conversation for today.
Yeah.
Any other questions?
okay. I actually think I've reached the end of my initial testimony. So let me just tee up my members. So there are 3 members, and I think you should hear from, I'm not sure what your list says, but April Plant from UVM Home Health and Hospice
Okay.
is going to be our first witness. So she's, I think what we want is for her to talk a bit about sort of the clinical realities on the ground. She's very close to this work as a clinical director for home health. And then Kathy DeMars, who's a longtime leader of the agency in Lamoille County. So she's a nurse leader. And then Sarah King, you've actually heard from this year. Who you may remember from a few weeks ago. And so she'll talk a bit about what's happening in her agency and some of the work that they do on safety. I think this is going to give you a good picture of what it really looks like out there and why we're asking for this. I will, of course, stay. I actually think it might make sense if I stay in the chair, if that's okay.
Yeah.
In case I need to interject or help clarify.
Okay.
Okay.
April, welcome.
Hi, thank you. So as Jill said, my name is April Plant. I am a registered nurse and I am the Director for Adult Home Health Services for UVM Health Network Home Health and Hospice. I wanted to start by thanking you for inviting me to speak today. There are a few points that I'd like to focus on during my time with you this afternoon.
Great.
So the first thing I'd like to talk about is just what it's like to go into someone's home and provide care. So home health clinicians provide a wide variety of services to patients in their home setting. Some examples of these home settings can be a little bit more complex. So it would be the patient's own home. It could be a family member's home, a relative's home. It could be a room in someone's home. It could be an apartment or a hotel room. When our staff make these visits, they are alone, and oftentimes due to the geographical service areas that we provide care in, they don't have cell phone service. So when we say alone, they are really alone in that environment with the patient. as many of you can probably understand, these home environments can look very different from one patient to another, and they can all present a variety of safety challenges at any moment. We do train our staff to be aware of their surroundings when they're making visits and treating patients in the home environment, but unfortunately, oftentimes these issues kind of present spur of the moment when the clinician is already in the patient's home. And so it really puts them in a position of needing to figure out how to handle and navigate that situation by themselves and in the moment. We really encourage staff to bring forward even the smallest concerns so that we can discuss them, understand the situation, work with the patient and the clinician to try to identify what's happening, if there's an ability for us to mitigate that situation, and work on a solution so that we can ensure we're able to continue to provide care to the patient, but also to ensure the ongoing safety of our clinical staff. On a daily basis, I think home health and hospice agencies really are, as Jill said, in a really tough place with navigating the challenges of balancing the commitment to serve the community and the responsibility that we have to protect our staff. And I want to talk a little bit just about some of the probably some of the most prominent safety risks that our home health clinicians face. So I know Jill mentioned a few of these, but unsecured weapons, unsecured animals, unknown individuals in the home environment. Sometimes that's when a clinician arrives to the home, there's someone in the home that doesn't normally live there or reside there, or folks that may arrive to the home environment at the time of a visit while the clinician is there providing care to the patient. There's instances of aggressive or threatening behavior, and that can be specific to the patient, a family member or caregiver in the home, or again, an individual who may not reside at the home or who may present to the home during a visit. And then environmental hazards. So some examples of that would be improperly disposed needles, sharps, mold, poor structural integrity of a home environment, things like that. I'd like to take a moment to emphasize the lengths that we go to really ensure that we're exhausting all options in an effort to continue to provide care to patients. Many of you may be aware of the recent challenges that have presented at the Decker Towers apartments in Burlington. UVM Home Health and Hospice has continued to serve community members at that location by really putting tactics into place to ensure staff safety while caring for patients in that setting. And again, just for context, I know Jill mentioned this, but the number of situations that result in an actual discharge from home health services are minimal. We really do put any and every effort into mitigating safety risks and working with patients and families to try to remove barriers so that we can continue to provide care while maintaining this safety of our staff. I think the unfortunate truth is that the frequency and severity of these situations and occurrences has increased beyond what home health agencies and community partners can manage with current staffing capacity. As Jill mentioned, with the local police departments, their staffing capacity is limited just as ours is. So, really, really difficult for us to manage with that current staffing capacity, with the tactics that we've put into place and with the resources that we have available to us. So I want to conclude by thanking everyone for giving attention to this really crucial topic. The safety of our home health providers is essential to be able to continue to provide this care to patients in the community. And it's really a service that allows us to keep patients in their home and allows people to really heal in the place that they want to heal, which is their home environment. So
Great.
Thank you.
Thank you, April. Any questions?
I have one.
Sorry, hold on. Let me just, you good? Okay. Art.
Yeah, April, I wondered, do you have any idea of the percentage maybe of violence that might come from a patient who has like dementia or Alzheimer's, something where they don't mean to be violent, but they're surprised or afraid of you as a clinician.
Mhm.
Any sense of that? I mean,
Yeah, I don't think that's our main, I don't know that I have a specific percentage for you, but I certainly don't feel like that's our main challenge
okay,
with
that's
safety.
all. That tells me what I want to know.
Yeah,
Okay.
when those situations do present, we work with families and providers to ensure that we manage those situations. And oftentimes, if the
Okay.
patient is struggling with that, it's not just us, it's the caregivers in the home environment that are facing those challenges as well. So that's certainly not the majority of this population by far.
Okay, thank you.
Madam Chair, it might be helpful to hear from all three witnesses and ask them questions as a group. I just want to suggest that, yeah, just to,
Yeah, yeah.
yep.
Sounds good to me. So who did you want to come up next?
Kathy.
Great. Hi, Kathy.
Hi, everyone, and thank you for having us testify. We appreciate all your time and hard work. I have been at home health since the start of my nursing career 34 years ago, so all I know is home health, and it certainly has changed over the years. My board chair asks me at every board meeting what keeps me up at night, and I have to say staff safety is probably the biggest issue that weighs heavily on my mind all the time. It used to be girls or staff were going out in the middle of the night because they're on call 24 hours a day was my biggest concern, but now it's even daytime. We're going into some pretty scary places, and this is even in Lamoille County, so it's not just the big counties, it's happening in the small counties too. I was going to tell you about a few stories that we have had here that we've dealt with. The first one I want to tell you about is a nurse that we were going to admit a patient. She called the patient's home, set the appointment to come to this house. It was all set. She was there at the right time. And when she pulled in the driveway, a man came out the door, greeted her in the driveway with a rifle in his hand, both hands on the rifle, wanted to know who she was and what she was doing there. And once she told him why she was there and who she was, he proceeded to walk her into the house. He put the gun down at that point by the door. She went to see the patient, and then he came in, took his sweatshirt off, and there was a pistol in a holster that he had right standing by her. She did admit the patient, did all his care, came back to the office quite shaken, as you can imagine. And what we decided to do with that patient was I called him directly and asked that either we see him in another home, a family member or a neighbor's home, or that this person couldn't be present while we were there. He chose to be seen in another home, so we provided the care, but it really did traumatize this nurse. She was also afraid to look for help. We have alert media on all our phones and tablets so they can get police help, but she was afraid if she pushed it, he could either hurt her, or if the police came into the yard, they could hurt them. So she didn't use her system, her safety system, because she was afraid for herself and for the police at that point. I have another story of a physical therapist, so it wasn't just a nurse. So she was outside walking with a patient, and this patient was really thankful that she was walking, the PT was walking with her because she was going to testify against some local drug dealers, and they had threatened to kill her. And she said to the PT, "I'm really glad you're walking with me because I don't think they'll hurt me if I'm with you." So that, of course, the PT was very, very nervous. In this particular case, the patient switched from Medicare to Medicaid, and we were able to have her go to outpatient physical therapy. So she again received the right treatment. And then the third case that happened not long ago was a nurse went to see a patient in a hotel room. She had to do wound care. She was one of my more seasoned older nurses. When the patient answered the door, he had absolutely no clothes on, greeted her at the door like that, and quote said, "Hey baby, I'm ready for you." Being older was a benefit for her because she said to him, "Turn around, get some clothes on." She shut the door and waited for him to open up. But if I'd had a younger nurse who shut the door and came back to the office and said, "I'm not going in there," I wouldn't have blamed her one bit. So he did specify that he wanted a specific nurse who happened to be a younger, pretty nurse. Of course, we never sent any of our younger nurses in there. It was our older nurses that we continued to send in, and he behaved better with them. but there are those circumstances where you just don't know who's going to answer the door or who's going to be behind the door. And it's really scary out there. What we're seeing in a lot of the homes are families are wrapped up in dealing drugs and doing drugs. It's not the patient most of the time. It really is who else is in the home. You know, there are guns laying on tables, there's cocaine on tables, there's needles on the floor. And then some of these houses they go into, there's 5 locks on the door. And as soon as the clinician goes in, they lock all these locks because they know somebody could be coming. So they're locked in, which is kind of scary when you can't get out quick enough if you need to. So I think my point is to say that every single circumstance is unique. No 2 cases are the same. And most 99% of the time, we can find a way for the staff safely to see somebody. But there is those cases that we just it may not be possible. So we're asking just for this little bit of flexibility, just to help us protect our staff. I'm planning on retiring in the next year or two, and the most important thing to me right now is to get all these safety measures in place for the staff. And if we want to attract young staff, I think we have to have all these things in place to protect everybody we possibly can. So thank you.
Great, thank you, Kathy, and thank you for your years of service. I think we're on to Sarah, and then we'll open it up to questions.
Good afternoon, everyone. Thank you for inviting me again. I'm Sarah King. I'm the CEO at the VNA and Hospice of the Southwest region. We cover Rutland, Bennington, and now Franklin counties. I have been in home health now 23 years, and I concur with what Kathy said. The business is a lot different than it used to be. Similar to the testimony of April and Kathy, many times the safety issues that our staff are encountering are not the patient. It's rather another resident in the home, maybe a family member, maybe someone who's just couch surfing. So that's what we are encountering. I want to share with you guys a recent situation that happened to one of our clinicians last fall. She was out making her scheduled visit. It was out on a remote area in the Lake Bomazene area. And she got to the home and was providing care to her patient. And the son that was living with them was intoxicated. And during the visit, the son was becoming more and more agitated, and he was going in and out of the house. He took the keys to his father's car, drove down the road once, came back, again, intoxicated, and then became very verbally abusive to both our clinician, to the patient, and to the patient's wife. There were twice during that visit that lasted about an hour and 10 minutes, 911 was called. They didn't respond, but they wanted to report the incident. So the clinician remained in the home. She completed the treatment for the patient. She instructed the patient to continuously call 911 if the son remained abusive. She also told them that she was a mandated reporter, and the father said, "You do what you need to do." So she gathers up her stuff and she gets in her car. And again, she's in a very remote area. And she looks in her rearview mirror as she's going down the road, and the adult son is following her down the road in his car, in his father's car, intoxicated. So as you can imagine, she was very rattled by this situation and did not want to go back into that home. What we did in that situation was we came up with a contract so that that adult son could not be in the home while we were in there. But what happened was he was sitting in the driveway. So we did eventually have to discharge this patient because the staff did not feel safe. They didn't know if he was going to try and run them off the road. They didn't know what condition he was in. That's just one example on top of what Kathy and April have shared with you guys. You know, our staff are going into these strange homes every day, all alone. We don't know. Some of the homes that we go into look harmless, but when you get beyond that front door, you do not know what you are going to be facing. And as Jill said, we're required to go in there. So my agency We have been lucky enough to have the resources available to us that I hired a director of operations, safety, and security. He's a former police officer, and he actually focuses on staff trainings. We have provided every member of our staff, office and otherwise, pepper spray training, and we've given them pepper spraying. When these circumstances come up, he offers one-on-one coaching and will even accompany some of the clinicians on visits. But unfortunately, there's only one of him, and we could send him out several times a day, multiple times a day with multiple people. And there's a cost associated with this that not every agency can absorb.
Right.
These staff issues are also becoming a recruitment issue. In the last 2 orientations I've had new employees ask me, what do you do for safety? Because it's in the media everywhere about what's happening in all facets of healthcare and workplace violence. And people are asking me. I do think that it gives them some reassurance that we provide these safety issues, but to have some legislation that we can actually fall back on and say, we don't have to go back in, would actually give them even more peace of mind.
Thank you, Sarah. So I think I'm going to use that as an example, hopefully to flush out what you're asking us here for, so we're all on the same page, and then we can open up for questions. And I also want to say Chair Wood from Human Services walked in, so if you have any questions, obviously let me know. So in that last situation where you did discharge the patient due to safety, that's allowed today in the rule. Let's say that patient was back in the hospital for something else in 3 months or even a week, let's go for a week, and had another referral to your agency. This language would, as it is today, you would have to take that referral. This language would allow you to potentially not take the referral, give you some flexibility on how you would handle it. Is that the gist of it?
Yeah. Yes. I'm just looking, making sure nobody's saying no back behind me. So,
No,
yeah.
right. All right. Any questions? Chair?
Hi, this is Teresa Wood from Waterbury Chair, Health Human Services. I'm just wondering, in the situation that Chair Houghton just asked about, how that seems like that's going to back people up in the hospital in terms of what they already cite is an issue in terms of not being able to discharge people. If one of the requirements is that they are able to have home health as follow-up. So what's your proposal to deal with that issue?
So we're talking about very few cases. We're talking about handfuls of cases across the state where people have been discharged for safety and at all, much less needed to be readmitted. So yes, it will be a person who's not able to come home to a home health service. I don't think it's going to have a significant impact on that problem. That is absolutely a problem. But I don't think I just think it's so few people that I don't think it's going to change the trajectory on the discharges. I don't know if any of my members have a different comment. Sarah?
I'll just speak to that for a moment. Many of those border patients in the hospital do not qualify for home health for various reasons. They either don't meet the Medicare requirement of being homebound. They don't require a skill, because remember, if we go in for home care, they have to either need speech therapy, physical therapy, occupational therapy, nursing. And so I know that the boarders that are sitting at Rutland Regional Medical Center and SVMC are not patients that qualify for home care services.
Yeah, I guess I wasn't just speaking about people who are there now. I'm thinking, we could have a situation where somebody had a knee replacement or something and then was going to need physical therapy at home and, was not going to, maybe has a home situation that's as you described. So I just think we need to be aware of that potential unintended consequence of what you're asking for.
Yeah, I think that person also might be able to be served in an ambulatory setting, potentially less convenient for them, absolutely. But the other piece is that there is this, I'm really concerned about the work. I'm more concerned about the impact on the workforce of how scary it is out there. And our workforce is, I think, much more significant impact on ability to take discharges than these very few cases that where there's already been a safety discharge and the person is being readmitted. I think that our capacity to recruit is a far bigger concern. So there's no perfect solution here, but I'm way more worried about people being willing to come to home health at this point in time than anything else.
Art?
The folks that are in a long-term home health care situation, and somewhere along the line, I mean, maybe years of continuous care.
Mhm.
If something were to happen, a long-lost son comes home, like we talked, and there's a violent encounter, and you discharge, how would that, I mean, is there a length of time, or do they check back and say, is this individual out of the home? How does the mechanism work? Just so you, because what you have here, I totally agree with.
Yeah.
I just wonder what mechanism happens after.
Yeah.
For those type cases.
Right, you're talking about for people who are on services for a long time because they're more on like a choices for care kind of service.
Yeah.
Yeah, and whether or not there's an opportunity to sort of readmit them onto service. Yeah.
Yeah, I guess, yeah.
Yeah, is that what you're saying?
The
Yeah.
admission and discharge is fuzzy to
Yeah.
me because
Yeah, because there's different kinds
they're
of service.
sitting there.
There's different
Yeah.
kinds of services. So,
Yeah.
and actually it's let that for, I mean, in terms of our ask, that it's less of an issue because there's not the same sort of readmission process for a long-term care person as there is for a skilled home health, where it's an intermittent service
Right.
that people go in and out
In and
of.
out, right.
Yeah.
And I want to be clear, we're talking about skilled nursing
Yeah,
here.
yes, this is really, and this really impacts our skilled nursing side because of the readmission
Readmissions.
piece. Yeah, there isn't really there isn't really a relevant, but it's a fair question. There
Oh,
are,
this isn't for those type cases, you're saying?
it's
or-
more that because there isn't a readmission process in long-term care, there's only a readmission process in skilled. Those are the only people
Okay.
coming in and out. So we don't have the problem to solve. It is a problem for the person because they have been discharged from long-term care potentially. It doesn't happen very often that someone is discharged from long-term care.
Okay.
There'd be a lot of work to try to work with that family, really try to figure out a contract with that
Yeah,
patient,
yeah.
tremendous amount of work. It can happen that they're discharged for
Yeah.
safety. That's allowed under the rules today.
Today, okay.
Mhm,
All right.
yeah.
Any other questions for April, Sarah, or Kathy before we go to our next witness? All right.
Just a comment. I just appreciate all of the work that's being done in hospitals and and outside of hospitals around workplace safety. And it's unfortunate that it's gotten to that point, but I'm really grateful for the shifting from, I think, those in professions that are thought of as being like value centered. I can't think of the word for it, but where a nurse is doing what they do because they care, and that's their motivation, and they should continue doing that regardless of the conditions that they're working in. It's their calling, so to speak. I'm really glad we're getting away from that for all healthcare professionals, and creating a culture of safety.
You mean the idea that because it's a calling, it's okay that it's unsafe?
Yeah.
Yeah, no, it's still not okay.
Yeah.
Right? That's right. Exactly.
We talked about that yesterday. Was it just yesterday? We went
Yeah.
to we talked about, I know you went there, but we talked about that there too, that the same issue, right? It's a calling, so you are a nurse in a hospital, yet the violence is gone.
Yeah. Yeah.
And sometimes we're hearing more and more across our healthcare system about the quadrupling of healthcare, and this is really it, and that's taking care of it.
Mhm.
Thank you, Mari, for.
Yeah, I really appreciate that. Well, and really, in a lot of ways, the future of healthcare is actually in the community and in the home. I mean, that's where we want to see more care in the home. We want that to be more possible, and more with technology, there's more and more that is possible to do in the home, but we've got to make that work. And I think, I think what we're experiencing is that there are societal issues that are sort of beyond the scope of what a healthcare provider can manage. And so we do have some grappling to do to make all of that work. Yeah. Thank you so much for the opportunity to testify. We really appreciate
Yes.
your attention.
Absolutely. Thank you, Jill. Thank you, April, Sarah, and Kathy, for your testimony and all that you're doing for Vermonters. So we're gonna switch to, is it Kaylee? I'm sorry, Kaylee, you weren't in the room, so we didn't connect beforehand.
Oh, that's all right. I'm Kylie Kuiper. I'm the state long-term care ombudsman at
Great.
Vermont Legal Aid.
Welcome.
Hello. Thank you for this opportunity. So I just wanted to, for those who aren't familiar with our program, we advocate for individuals who receive long-term care in facilities and also people who are receiving long-term care in the community through the Choices for Care program. As I'm sure you're aware, Vermonters who are denied necessary skilled nursing are likely to end up in health crisis. I'm concerned that the current language is not sufficiently clear that whether individuals can be denied these services without any further process. So I think it's important that we add language that clarifies that these individuals will be given the same notice and appeal rights as someone who's applying for the first time. Notice and appeal rights are important because denials can be based on unfair biases. They can certainly be based on outdated information, or they can be based on mistakes. You can have two people with the same name, or things like that that can cause inaccurate denials, and people should have clear notice of why they're being denied and a chance to correct the record. In addition, there's people, especially after they've had a recent healthcare crisis and need to return to skilled nursing. There's people that will say, you know, before I wasn't willing to do what I needed to do to make this safe for the VNA to come in, but now I'm willing to get rid of the problem animal, or tell my son that, you know what, he just can't be here. So I submitted some written testimony that included specific language that I think is pretty straightforward, just saying that the people that are denied care for this reason still get the same notice and appeal rights as someone who's an initial applicant.
Great, thank you. And I'm looking at this right now. We will have our ledge counsel is not in the room looking at that with us. Questions, Leslie?
Yeah, thank you. I'm not sure I understand what the appeal rights are for initial applicant.
Sure. So my understanding is that they receive a notice that is required to explain clearly and in plain language why they are being denied. And they have an opportunity to write to Dale and say that they believe that they were unfairly or incorrectly discharged, and Dale will assess that appeal.
But why, man? But why would an initial applicant be denied under safety concerns?
So, and
Maybe we're in another section.
no, so, and Kylie, help me, I'm gonna try and rephrase what I think you're asking. So a person is referred to home health. They go in, they care for the patient, something happens, they are discharged for safety.
Okay, that's the initial one they're talking
The
about.
person, right? So there's an appeal process there. And I think the concern is, and correct me if I'm wrong, please, that this language now puts in the option where if there's a second referral, home health can choose not to go in. You want to make sure that the same process is used on that second decision. Is that accurate statement, Kylie?
Yeah. So
Okay.
if there's so the person is definitely notified that they were denied. That's the first thing, that, you know, we don't want a situation where just no one ever comes in. And the second thing is they have a chance to read the reasoning and either correct the record or correct the situation that's causing the problem.
Great.
So maybe Ledge Counsel can help. I'm obviously having syntax problems the last couple of days, but when it says initial applicants, that's what's confusing me. Because it implies that they haven't gotten care yet because they're an initial applicant. Well, that's what I'm unclear about.
And her language specific?
Yeah. Mhm.
Okay, so I just want to make sure we're on the same page. So the language that's being requested to be added is the home health agency and the Department of Disabilities, Aging and Independent Living must provide individuals who are denied admission or home visits under the section with the same notice and appeal rights as provided to initial applicants. That's the issue.
Yeah.
The same notice and appeal rights as provided to initial applicants.
So what are initial,
It's that first, so the person has been referred from home health, they've been treated, they've been discharged for safety. That's that first,
Initial.
that's the initial. Now they go back in the hospital for something, they get referred again. And we put language in, home health could say, I'm sorry, we're not going.
so it would be who were denied. Okay, I think I just need help with language.
Okay, and but do you understand the concept?
Totally.
You're just worried about the language,
Yes.
like okay,
Yeah.
so we'll deal with that with Katie. Okay. And thank you for
Putting up with me.
walking us through that. So other questions for Kylie? No? Great. So we will, Tucker.
What happens in between the time they've been denied, they still need a service, and the home health agency is saying they won't go?
I think that's a really important question. At this point, I was most concerned that people might not receive any notice and might not have any appeal rights. I decided not to go into the, I mean, I think that something that could be spent some time on which situations should they have to go back to for another in-person assessment, and which situations is it fair to say that they shouldn't have to go back while they're assessing the application. And I think it's a complicated discussion. I think it's fair to say there are some situations where they shouldn't have to go back, but obviously the best assessment and the best care would be to continue to go in.
Yeah, no, and you don't feel that under section 3, where it says in the behavior or conditions causing the discharge cannot be reasonably mitigated or eliminated, you don't think that's good enough?
I think that the people who are being denied care should have clear notice that they're being denied and the reasons why. And because there could be mistakes and there could be changes, you know, the husband who was causing the problem may have passed away since the last time the VNA visited. Some of these individuals are going to be domestic violence victims, and potentially the abuser has been kicked out of the house or is incarcerated. I just think it's important that we give people an opportunity to respond to the denial.
Thank you.
Thank you.
Great. Thank you very much for your time. All right, I think we have Morning Fox next. Is Morning on? Oh, there he is. Oh, with a nice, really pretty picture. We like that picture. We like your face too, but that was a lovely picture.
Not as much as your dog.
There you go. That's my dog. Yeah.
Don't fool around with me, may lose you.
Welcome.
Thank you. Thank you for having me. And for the record, my name is Morning Fox. I'm the Director of Mental Health Programs for the Department of Public Safety. I will keep my comments brief. Today's been a long, arduous day, and I'm just trying to get in my testimony before my power and Wi-Fi go out again.
We appreciate that.
So, and I apologize. As you all know, I much prefer to be in person than via Zoom. But I'm at 13 inches and still counting.
Wow.
Right now.
Wow.
So,
yeah, but we're glad you're there safe.
No, thank you. Me too. So my comments are focused on section 1 of this bill, and had worked with the Department of Mental Health and the Department of Health in looking at this language, and we all kind of have agreed with that. We're comfortable with how this language has progressed through the Senate and come to you folks. We share the vision that DMH testified to yesterday in regards to having more standardized responses to folks who are experiencing a crisis. I have had numerous conversations over the years with Senator Lyons regarding just that topic, and so it came as no surprise, really, this year that Senator Lyons put forward this bill with an effort to really help with some fidelity around various responders who could be responding to a person experiencing a crisis, and having the flexibility within these guidelines is incredibly useful, so that the various players who may be a responder to a person in crisis can adapt and incorporate parts or all of the guidelines into their own individual policies. But just like EMS have their policies driven, from one place, law enforcement has them driven from another, as you heard from Assistant Director Brickell yesterday with the Criminal Justice Council. And so knowing that there's all these kind of various entities overseeing different folks' responses, having the flexibility to be able to take these guidelines and adapt them into various policies through different departments and agencies will be much more helpful than setting one set of protocols that could potentially become in conflict with other protocols that are already set.
Great.
And I will stop there and answer any questions.
All right, that was short and sweet. Any questions? Go ahead.
Thank you, thank you. I always worry that we do a lot of work and get a set of guidelines and they sit on the shelf. Do you have any thoughts about that?
Well, my testimony, as well as the testimony from the Department of Health in the Senate, and I will repeat what I said there, which is we're committed to working with the Department of Mental Health to help develop these guidelines. And then we're also committed to, through our policy, now I'm losing my words right now, but through our normal policy practice of reviewing policies and adjusting policies within public safety, that we would take these guidelines and look to see where they can be incorporated into our policies. And we commit to being able to do that. And as well as the Department of Health has said the same thing in Senate.
Thanks.
Courtney, I have a question. So, actually, I answered my own question. I was going to ask the question, we talk about municipalities here and who was going to be speaking for them, but it does look like VLCT is on the list of people. Okay.
And I've made sure that folks from the league are aware of the bill and the language and, provide them context with it as well.
Okay, great. Thank you. And we might see if they want to come in. Okay. Any other questions for morning? Great, thank you. Go start shoveling.
All right, I'm ready to snow blowing. I'm going to do another.
Good luck.
Thank you.
Lynn. I think we're moving on to, when she comes, I think we're moving on to section 2 now. Hi, Lynn.
Hello, good afternoon. Thank you very much for the invitation to present. For the record, my name is Lynn Currier-Stanley. I am a social worker and the executive director of the National Association of Social Workers Vermont chapter. I am also the executive director for the New Hampshire chapter. Thank you very much for hearing my testimony on the amendment around setting up a committee to review the research, dive into what possible solutions there might be, where are there needs, and where are there opportunities to increase safety for social service providers. Last year, Alex Magalese, who's the partner of Leah Rosen Pritchard, the social worker who was killed in Brattleboro last year, reached out to me and says, there's something we can do. And I see this as a much needed jumping off point. I know that a lot of work has been done. However, we've seen, and just from the testimony given a little bit earlier, there are some definite unaddressed needs in places where we probably could be doing a better job. And this committee would be able to look at what can be done, what the research says, and making some suggestions for the future. I'm keeping my testimony very short, but I'm very happy to answer any questions that you might have.
Great, thank you. Art?
Yes, the question I have, I guess, in relation to the incident in Brattleboro was, and I don't know if it's even supposed to even answer the question. It was the perpetrator a patient in that case? Do we know?
Thank you for the question, and I'm not sure I can answer that. I don't have any firsthand knowledge.
Okay, I only ask because it's a little different than section 3 where we're dealing with.
Right, so this is section 2 is what.
I understand. Okay. I'm just trying to draw a parallel where.
There wouldn't be a parallel in that because section 3 is home health only.
Right, but it's still a visit to a home. This is a visit to a person, right? So.
Your social service providers some go into people's homes, some are place-based where clients come to them, some are in the community. And that's why why the social workers weren't coming forward with, we need this specific thing, that we need to be able to look at all of the various settings, milieus, and make suggestions.
So, but the client could be violent in terms of this, correct?
Absolutely.
That's all I guess I'm trying to figure out.
Correct.
Yeah, okay, thank you.
Any other questions for Lynn?
I have a question for you now.
Yeah.
My question for you is, this section, the report only goes to Human Services, but not to us. But we are going to be voting on it. So I'm wondering.
I'm sorry, can you say your question again?
Yeah, in the presentation of it gets sent to House Committee on Human Services, but not us. The report.
Thank you for the question. I don't have the language right in front of me. It was my understanding that the presentation would be going to you.
Okay, yeah, thank you. So we'll just have to change that.
Thank you.
Yeah, sorry, I wasn't sure where you were in that. Okay. No. Lynn, I have a question. So does this group of people already meet today? Someone told me that the people in section 2, the organizations listed in section 2 already meet today. Is that not the case?
Thank you for the question. I believe that people are meeting. Whether or not it's on this topic, I think I don't believe so.
Okay.
We meet and work in partnership with a variety of different organizations on a variety of different things, but not specifically that I know of.
Okay, got it. And are you speaking for all these other groups? Have they all been? I don't know where this was in the Senate, what testimony was taken. So have you talked with Network Against Domestic and Sexual Violence, Coalition to End Homelessness? I mean, is this something that everyone agrees should happen?
My understanding is yes, that I believe everybody that's on the list has been contacted and is in agreement.
Okay. All right.
Is there a procedure today when something like the incident in Brattleboro happens? Is there something, an after action report type thing where you investigate it? Is that in place?
I believe it depends on the organization itself. Like hospitals have critical incident debriefs where they meet, and for some, it's kind of that ad hoc meeting that comes together to look at whether some organizations have set policies on this is what happens when, others do not.
Really? Okay, thank you.
Great. Leslie?
Well, I'm just going to refer to Brattleboro if I may. I know that AHS was deeply involved in the debrief there.
I
Just
mean,
so you know, it was
it
not
concerns
local.
me that there's not a procedure
Yeah, I think. there's-
statewide.
I think,
Well, Agency of Human Services would be in charge of
Oh, okay,
doing that,
Yeah.
yes,
and they were deeply involved.
yes.
okay.
And I believe there's a difference between when there is a death as opposed to an injury or a potential injury.
Yeah. Okay, thank you.
All right, great. Thank you, Lynn. We appreciate your testimony.
Thank you very much.
So I think.
Can I ask a question? Sure. Language question, because commenting, as I'm looking at the list that you, this is more for you, like, maybe I'm not sure. Should we add a G and other organizations deemed appropriate, or does that? I'm just not, it's a complicated list.
It says may be included in the lead into it, so.
May be included, but not, if they're not included, then they wouldn't be included. I'm not sure. I feel that language is kind of. Not
If
sure.
if I may, our
Sure.
intent is to invite any and all who we believe that the more people who are bringing together ideas and suggestions and opportunities, the better. We want to bring people in, not keep people out from the conversation.
And I would agree with Mari's statement that it says may be, so this isn't a shall list. And so,
But it doesn't say HS or,
AHS is convening the group. The Agency of Human Services.
Yep.
Will convene.
Yep.
Along with.
So that means they're sitting, I guess when they're convening it, they're in the room.
Yeah. Yeah. Any other questions specific to Lynn? Great, thank you, Lynn.
Thank you.
So we have a couple different things because it's 3 separate bills. For section 1, I think there was a suggestion, Daisy, to add the state standing committees.
Yeah.
Okay. And then, so let's stick with section 1. Is there anyone else we need to hear from for section 1? Is everyone comfortable with the testimony we've heard so far? This section, just so everyone knows, I've talked to Chair McCarthy in House Government Operations. I'm going to send him the bill. He may need to look at this as well because it includes municipalities, but I'll deal with that. Everyone seems okay with section 1?
I'm okay. I'm just wondering, the Vermont League of Cities and Towns is listed. And I'm just wondering if the Chamber of Commerce should be listed too.
Well, except they're listed because it deals specifically with municipalities. I'm not sure what the chamber's role would be.
Chamber doesn't do anything with emergency response.
Right.
No, I guess they are. I was thinking of all of the businesses and stuff. Oh, that's okay. Okay.
Okay.
Are there, another one, any specific representatives from the veterans community?
Okay.
GovOps might
Yeah.
be able to.
Well, except it's in any other entity.
Right. There isn't any other entity department.
Which is what I'm responding to in
Okay.
section 2.
Yeah. Okay. All right, so we'll float that out there. Section 2 is what we just heard about with the social workers. I want to try and get AHS in here since they've been requested to convene it. We can talk to Katie about adding and any other language deemed appropriate or any other entities. Anything else on section 2 that you guys are thinking about? And this isn't the last time we're going to talk about this, but there's people we want to hear from. I want to get it out now.
I know the bill is, again, focused on, provider safety. I'm a little uncomfortable that we haven't heard from anyone with lived experience.
Okay. Like
A family member or someone that can speak to, like, we've heard the provider side and like definitely understand where they're coming from.
so wait, I'm sorry, are we still on section 2 for this is the
Yeah,
the working
well,
group?
that's specific to the provider. I'm looking at B at least in that group. Is that what you're looking at? Because those are entities, but I'm thinking about having overall in the bill, having the perspective of what it's like to go through one of these
Okay.
incidents or need care for a family member or yourself and not be able to have it.
So someone with lived experience.
Yeah,
You're saying you want that added to the list?
yeah,
Okay. In 2.
yes.
Okay. Alyssa?
Well, I kind of said this yesterday. Vermont Legal Aid has their, and I know that they deal with like mental health law and they have that mental health project.
Daisy might know the answer to this better than me.
But they also like advocate for sort of like the needs of those in the community, lived experience.
Well, NAMI's on there. NAMI does as well, and Vermont Psychiatric
Yeah.
Survivors.
Yeah.
Is like kind of a more specific group of folks, but.
Okay, so now you guys are in section 1. Can we?
Wait.
Well, yeah, and
So we
overall
need
the
to
bill.
be, right, but so we need to, because they are 3 different things, right? So we need to work on each section at a time, because we can add the same thing to all 3 sections, but these are 3 separate things.
Okay, so in the development of, section 1.
Yes.
Is where I think it would be really important to have those guidelines informed by people who actually receive the services or need to receive the services.
Okay.
They should be a collaborator in working to develop that policy.
So people with lived experience.
Yeah.
Okay. And the group you were talking about.
I'm rescinding what I just said.
Okay.
I'm fine with the list as it is.
Okay. So then in section 2.
Yeah.
Someone with lived experience as well.
That doesn't fit the language, because
Right.
if you go down to the list, it says so community-based social service organizations and professions. So people with lived experience are not.
But that doesn't mean we can't change it.
Yeah, always, I think people.
Okay.
With lived experience should comment on
Following
it.
community-based social service organizations, professions, and those with lived experience may be included in the meeting.
Yes.
Okay.
Um,
Oh, thank you. Hi, Brian. Go ahead. Brian, Gina?
Yeah, I'm on my phone and it takes a second to get from reading the bill to unmuting. So
No, that's
sorry
fine.
for that.
No, it's
I'm
fine.
gonna look at it while I talk. So
just Brian, can you make sure you're talking by section? Like-
yeah, that's what I was gonna try to do. So
Okay.
can you hear me okay? Because I have an earplug thing in.
Yes, we're good. Thank you.
Okay. So I think that we're in section 1 when it talks about the department developing guidelines and how they should consult with entities, that it lists organizations and it does say any other entity, but we may want to hear testimony from some of the other possible entities, even if they're not listed here. And I think you mentioned, I think Daisy might have just mentioned NAMI, but and Psychiatric Survivors is there, but we may want to hear from Mad Freedom in testimony, which is Wilda White's organization. We may want to hear from, it does show, it has state agencies, and I see there that it has advocacy groups. We did hear from the NASW, which represents providers. And I don't, have we heard, we have Vermont Care Partners, which represents providers, but they, like, Vermont Care Partners is contracted or paid for by the agencies. But I'm wondering about hearing from like healthcare unions, perhaps in testimony, at least, like not just in terms of maybe making sure we hear a little bit more before we pass it. And
So
that's
Brian,
a few.
can I ask you what the goal is about? Not that I won't bring more people in.
Yeah.
Are you
hear
asking
more
because
about-
you want them to have you want them to say, yes, they agree with the language, or what are you asking for?
Yeah, well, I guess because what we're doing here is saying we're not really talking about what the content of the guidelines are going to be yet, but it might be good to get on the record providers a few more people talking about the experience they have from different angles. Like where we heard about the angles from the nursing, but like maybe actually hearing a little bit more from people from the workers who are going in and doing it, not from the administrators. That's what I was getting at. But it's just I'm not asking for that. I'm not asking for that. It's more like the question I heard was like, is there anyone else we want to hear from? And I'm just making an exhaustive list of possible people. You know what I'm saying? We don't have to hear from all these people. Like while you were talking, I was like, who else could we possibly hear from?
Right.
That's really the angle I'm coming from. So similarly on section 2, I think those same groups could be consulted. I don't know if they have to be.
Okay.
For section 3, I don't know. I guess for section 3, we're just wanting to hear a little bit more, maybe from the perspective of the patients, before about that, maybe but I don't know if we need to hear more from the providers because it does seem to be more of a health home agency issue, and we heard from the providers there. So maybe that would be just hearing if there's any concerns from patients. And it might be good to hear from a patient who says this is good because or someone representing patients, because they might say this is good because it gives the patients something to point to when their family members are getting in the way, kind of a thing. But anyway, those are my thoughts, is like maybe hearing from did we hear from the healthcare advocate yet about this, Bill?
No, we have not.
Yeah, so I mean, the healthcare advocate might be able to speak from the patient perspective, but like I was thinking more like Mad Freedom or
Brian, were you here? We just heard from, and Kaylee's still on, and I'm not going to get the exact.
I
right?
might have missed that moment because I went into, let me see. I might have missed that moment because I was in here and then I went into another meeting. So.
And Kaylee, can you? I don't want to mess it up. Can you say your title again and what your role is?
Sure. Kylie Kuiper, State Long-Term Care Ombudsman at the Long-Term Care Ombudsman Project at Vermont Legal Aid.
Okay.
And so you look out for people in Vermont that are getting
part of it.
Right.
Yeah, I caught part of that then. I remember that. So it wouldn't be that's the perspective of the long-term care ombudsman is like parallel to what the healthcare advocate does in general for people with access to healthcare, but it's more focused on, so perhaps then that is sufficient. You know, we don't need to hear from the healthcare advocates also, but I was just thinking divergently, not convergently, like anyone else we could possibly need to hear from, not anyone who I think we need to hear from, if that makes sense. So.
Gotcha. All right. Thank you, Brian. Mari?
Mine's about section 3.
Okay.
The people I was talking with you about earlier, that might be helpful in dealing with the conundrum of providing patient care and worker safety at the same time. The ethics providers, some of us received an article from a colleague today that talked about the sort of the recipe or the algorithm for making clinical decisions when there's two valid but competing circumstances happening at the same time.
Okay.
So if if committee members are struggling a little bit to process how to provide care when patients need it and provide worker safety, and those two are like at loggerheads, ethics is an amazing tool to help walk through that. So
Can you share the article? with
yeah, I'll share
people?
the article, and then it might be worth having one of the writers of the article, they're from, at least a couple of them are from UVM Medical Center, come in and talk with us about the ethical dilemma.
Alyssa, and then Brian, I mean, Bobby.
I just wanted to say, I wanted us to like refocus on what this bill is trying to achieve. And sometimes in this committee, which I think is a wonderful thing that we do, but we tend to like go off on lots of tangents and we tend to include lots of people. I guess I'm sort of asking that we focus the groups and organizations that will have the expertise to create guidelines in section 1 that will, we're talking about social worker safety. So do we really need every single organization in the entire world, or do we need people who need to develop protocols around social worker safety? And the same thing with section 3. I guess what I'm saying is, can we keep things focused on what we're trying to achieve in this bill?
Okay.
Thank you for allowing me to.
Bobby.
I don't know that Kylie Kuiper was trying to say, I think she was trying to get our attention when Brian was speaking. I don't know if she had some insights that.
Kylie, did you have something else that you wanted to?
Thank you. I was just going to say that Mike Fisher and I did discuss my testimony before I gave it. We were coordinating. And I also wanted to say that I think Disability Rights Vermont might be interested in testifying if you're going to take further testimony. I don't think they were available this week.
Okay, great. Thank you. Thank you, Bobby.
Sure.
Yes.
In section 2. Page 3. It refers to, it says, community-based social service organization and professions may review both studies related to social work, et cetera. Trying to figure out, I guess these studies exist.
Well, so I think we had this conversation yesterday with Leslie.
That was a little embarrassing, sorry.
No, but isn't it and it is odd language that I think we should change, but I think what it's referencing is they may review studies related to both social service provider safety and individual social service provider safety experiences. Not that there's 2 studies, but they can look at studies related to those 2 subjects.
Let's take out the word both and we're all good.
Right? Does that make sense? So it would read, in advance of the meeting or meetings described in the subsection, the participating community-based social service organizations and professions may review studies related to social service provider safety and individual social service provider safety experiences.
And my question is, when we use the term may review, what's the sense of even putting it in there? That's my point. Unless they're going to review it as to get ready to make this report.
We lost Lynn, so I can't answer that question. I would agree with you that it doesn't seem like it needs to be in there, but since it's a may, and they asked for it to be in there, I'm okay with letting it in there.
Yeah.
But yes, I would think if they wanted to review the studies, they could review the studies.
If they're important enough to be in here, they should review them before they do
the
work.
Yeah.
They're going to present findings and recommendations.
Yeah. Okay, so I'm gonna reach out to a couple of people. I'm gonna work with Katie on adding some potential language changes and I don't think this is on our schedule for tomorrow, so we'll come back to this next week. That works for everyone. No, Samantha was just on in case there were questions. Yes. Listen.
So I'm just gonna say, really support section 3 as someone who did home health nursing in Brooklyn.
Oh.
And I had to go to places by myself.
Yeah.
In very strange circumstances and could feel the fear. So I appreciate a bit of protection. So
Yeah.
I think this is a good thing.
Yeah. Jill Olson is going to look at the language that was provided by Kylie and assess it, and she'll come back with what her thoughts are on it. I'm going to obviously talk to Katie about it, so we'll bring that back up. But thank you for that. Anyone else want to say anything in general about the bill before we close out? Okay, great. Thank you. We are back here tomorrow after the 4, I believe. So enjoy your evening, safe travels, and Megan, we can go off air if you're doing that, or wait, we're not off yet.
We're still closed, do we know?
There's a new one and where, well,
Hold on, everyone. We are not off live yet.
I know, sorry.
No, that's okay. I just want to make sure people don't. Can I just hit end?
Rude's not a person.